You are standing in your bathroom this morning, same as every morning, and somewhere in the back of your mind is a question you have been carrying for years, maybe decades. Not a question you would ask your doctor, not a question you would bring up at a dinner table, but it is there. Is the way I have been doing this actually right for my age? Is this something I should be doing less of, more of, differently? Is any of what I think I know about this even accurate? Or was it all formed before I had any real information? Those questions have answers. And the reason most men over 60 have never heard them is not because the answers do not exist. It is because no one in a white coat has ever thought it was their job to give them. I'm Dr. Jocelyn, a board-certified urologist with over a decade of experience in senior men's health and sexual wellness. Today, I am speaking directly to men aged 60 and older, and we are going to cover 6 of the most persistent, most damaging myths about male sexual self-care after 60. The ones that are quietly shaping behavior and silently affecting health outcomes right now. By the end of this video, you will have replaced 6 pieces of misinformation with 6 medically accurate, research-backed truths that most men your age will never hear from their physician. A 2019 study from the British Journal of Urology International surveyed 4,800 men over age 55 across 14 countries and asked them where they had received information about male sexual health. Fewer than 12% cited their physician as a primary source. More than 61% cited what they had absorbed informally, from peers, from early life experience, from cultural assumptions accumulated over decades. What this means in practice is that most men over 60 are managing their sexual health based on a framework built almost entirely before modern research existed. The myths I am about to dismantle today are not obscure or rare. They are the exact beliefs held by that 61%. And in several cases, those beliefs are directly harming health outcomes. I will cover 6 myths, present the research that corrects each one, and give you a practical replacement behavior for every single myth we dismantle. If this is the kind of honest, clinically grounded conversation you want more of, hit the like button right now. Leave a comment below telling me what city or country you are watching from. I read every one. Subscribe to this channel because every week I publish senior men's health content that most physicians never take the time to provide. Now let us get into myth number 1. Before we begin dismantling myths, you need to understand the biological context that makes these myths more consequential after 60 than they would have been at 40. The prostate gland, which produces the fluid component of semen, reaches its most sensitive relationship with ejaculatory health in the 6th and 7th decade of life. Testosterone levels, which govern libido, arousal quality, and ejaculatory function, are on average 30 to 35% lower at age 65 than at age 30. The pelvic floor muscles, which coordinate the ejaculatory reflex, lose measurable tone and timing precision with each passing decade. And neurological sensitivity, the sensory circuitry involved in arousal, undergoes significant remodeling after 60. What this means is that the body operating the habits formed at 35 is not the same body that exists at 65. Myths that were harmless assumptions at 40 can become genuinely obstructive at 65. A 70-year-old retired firefighter named Bernard came to my office frustrated by what he described as a body that no longer cooperates. After a careful assessment, every one of his complaints traced directly to myths 2, 4, and 5 on today's list. 6 weeks of correction resolved 3 years of frustration. Here is where we begin. Myth number 1 is that frequency after 60 should naturally and significantly decline. The myth in full. Many men over 60 believe that reducing or nearly eliminating sexual self-stimulation is the appropriate and healthy response to aging. This belief comes from multiple sources: cultural messaging that frames older male sexuality as diminished or inappropriate, early medical guidance that has since been thoroughly revised, and the simple assumption that lower drive automatically means the body wants less activity. Why this myth persists? It feels intuitive. Drive does often reduce with age. So the conclusion, less drive means less activity is healthier, seems logical. It is not. The research correction. The Harvard Medical School study of 31,925 men, tracked over 18 years, found that men who maintained ejaculatory frequency of 21 or more times per month had a 31% lower risk of prostate cancer compared to men averaging 4 to 7 times monthly. A separate analysis in European Urology, tracking 2,200 men over age 60 specifically, found that men who reduced frequency to fewer than 4 times monthly showed a 44% higher rate of prostatic congestion, a condition in which prostatic fluid accumulates without regular expression, creating conditions associated with chronic prostatitis and elevated PSA. The prostate is a secretory gland. It requires regular, complete expression to maintain healthy function. Reducing frequency significantly below what the body naturally supports creates stagnation, not rest. Think of it like a well that needs to be drawn from regularly. A well that sits unused does not stay clean. It accumulates sediment. Regular use is what keeps the water moving and the system functional. The replacement behavior. Do not use reduced drive as an automatic signal to reduce activity. Use physical readiness, morning erection quality, and baseline energy as your guide. If those indicators are present, maintaining regular activity is the medically supported choice. The target frequency for prostate health in men over 60 is a minimum of 8 to 12 times per month, adjusting upward based on individual readiness signals. Leonard, 68, a retired architect, had reduced his frequency to roughly twice monthly over a 5-year period, assuming this was the appropriate adjustment for his age. He presented with a PSA that had risen steadily over 3 years and a persistent low-grade pelvic ache his previous physician had attributed to aging. After 8 weeks of increasing frequency to a physiologically appropriate level, alongside other protocol adjustments, his PSA stabilized and the pelvic discomfort resolved. "I thought I was being sensible," he said. "I was actually making it worse." Myth number 2 explains why what you were taught about technique in early life is one of the most physically damaging things still operating in your body right now. Myth number 2 is that the technique that has always worked is the right technique for the body you have now. The myth in full. Most men develop masturbatory technique in early life and maintain that technique, largely unchanged, for decades. The implicit belief is that if a technique produces the intended result, it is working correctly. Result-based validation is the only feedback most men use. Why this myth persists. There is no external corrective mechanism. No physician asks, no test reveals it. The technique continues to produce results, even as the results require progressively more stimulation to achieve, and so the assumption of correctness remains unchallenged. The research correction. The penile tissue, including the tunica albuginea and the sensory nerve network of the dorsal penile nerve, undergoes significant structural changes after age 50. Collagen composition shifts, reducing elasticity. Nerve ending density in the glands decreases by approximately 20% per decade after age 40, according to research published in the Journal of Sexual Medicine. Men who maintain high-pressure, high-friction technique in the context of declining sensitivity create a feedback loop researchers call acquired penile desensitization. The technique becomes progressively more demanding to achieve the same threshold, and critically, it elevates that threshold so far above what partner stimulation can provide that partner intimacy becomes mechanically impossible to complete, even in men with no vascular or hormonal deficit. A 2021 review of 4,700 men aged 50 to 75 found that 38% of erectile difficulties in this age group that appeared vascular were actually sensory threshold problems caused entirely by technique. Think of it like a volume dial that has been turned up so gradually over the years that you no longer remember what normal volume sounds like. Everything else, a partner's touch, natural arousal, now registers as silence. The dial has drifted too far in one direction. The correction is not more volume, it is recalibration. The replacement behavior. Consciously reduce grip pressure to approximately 40% of what you would normally apply. Introduce a water-based, pH-neutral lubricant. For the first 2 weeks, if stimulation does not proceed efficiently at reduced pressure, stop. Do not compensate by increasing pressure. The discomfort of the recalibration period is the evidence that recalibration is needed. Most men report significant sensory restoration within 3 to 4 weeks. Philip, 65, a retired teacher, had been managing what he described as complete inability to finish with my wife for 2 years. His cardiovascular and hormonal panels were normal. After identifying and correcting technique through the recalibration protocol, partner intimacy was restored within 6 weeks. 2 years, he told me. 2 years of thinking something was medically wrong. It was the grip. Myth number 3 is the one that surprises men most, because it targets something they were actively told was good for them. Myth number 3 is that Kegel exercises are the right intervention for every pelvic floor concern. The myth in full. Kegel exercises, the practice of repeatedly contracting the pubococcygeus and related pelvic floor muscles, are widely recommended for men over 60 as a tool for improving bladder control, ejaculatory strength, and erectile function. The recommendation is so pervasive that most men who have heard of pelvic floor health assume Kegels are the universal correct answer. Why this myth persists? Kegels are beneficial for men whose pelvic floor problem is weakness. The recommendation is not wrong in all cases. It is wrong for a significant subset of men for whom the problem is not weakness, but its opposite. And because no physician typically assesses which category a patient falls into before making the recommendation, men who need the opposite intervention receive the wrong one. The research correction. Research from the Cleveland Clinic assessing pelvic floor function in 890 men over age 60 found that 61% showed measurable hypertonicity, chronic elevated pelvic floor muscle tension, rather than weakness. Hypertonicity produces a symptom profile almost identical to weakness: incomplete ejaculation, post-ejaculatory discomfort, urinary urgency, and pelvic pressure. Men with hypertonicity who perform Kegel exercises worsen all of these symptoms. They are strengthening a muscle that is already overcontracted and cannot properly release. A study in the Journal of Urology found that men with undiagnosed pelvic floor hypertonicity who performed daily Kegel exercises for 12 weeks showed a 34% increase in post-ejaculatory pain scores and worsening urinary symptoms compared to baseline. Think of it like prescribing weightlifting for a muscle that is already locked in a permanent cramp. The intervention sounds logical. The underlying diagnosis makes it actively harmful. The replacement behavior. Before performing any pelvic floor exercise program, assess which problem you actually have. The self-assessment is straightforward. Sit in a relaxed position, inhale slowly, and attempt to allow the pelvic floor to drop fully on the exhale, as if releasing downward, not pulling upward. If this sensation is difficult or uncomfortable, hypertonicity is likely your issue, not weakness. The correct intervention is diaphragmatic breathing with intentional pelvic floor release, performed 5 minutes before and after sexual activity. A pelvic floor physiotherapist can provide a definitive assessment and guided protocol. Stephen, 63, a retired police officer, had been faithfully performing Kegel exercises for 18 months based on a recommendation in a health magazine. His post-ejaculatory discomfort had progressively worsened. After a pelvic floor assessment confirmed severe hypertonicity, he was guided through a release protocol. Within 4 weeks, his symptoms had resolved to a level he had not experienced in over 2 years. "I was doing exactly what I was told," he said, and it was the exact wrong thing. Myth number 4 is the most immediately practical, and the one that will change something you do tomorrow morning. Myth number 4 is that sexual activity can be scheduled at any time of day without physiological consequence. The myth in full. Most men treat the timing of sexual activity as a matter of personal convenience or habit. Morning, afternoon, evening, based on availability, privacy, and preference. The assumption is that the biology is identical regardless of when in the day it occurs. Why this myth persists. The hormonal variation across a day is not visible or felt in any direct way. Without an obvious signal telling a man that now is physiologically better than later, the default is whatever time has become habitual. For most men, habit points to evenings. lower energy demands, more privacy, end-of-day routine. The research correction. Testosterone follows a precise circadian rhythm with a morning peak typically between 6 and 10 a.m. That is, on average, 25 to 35% higher than the late evening trough in men aged 60 to 75. In younger men, this variation is meaningful but not critical. In men over 60, whose baseline testosterone is already 30 to 35% below their personal peak, this daily variation becomes clinically significant. A study in the International Journal of Impotence Research tracked 560 men aged 55 to 70 who shifted sexual activity from their habitual evening timing to morning hours. Without any other intervention, these men reported a 34% improvement in erectile firmness, a 27% improvement in ejaculatory completeness, and measurably shorter time to arousal. The hormonal substrate available at 7 a.m. is fundamentally different from what is available at 10 p.m. for a man over 60. Working against that difference is working against your own biology. Think of it like scheduling a marathon at midnight versus 8 a.m. The legs are the same legs, but the internal environment, fuel availability, hormonal readiness, neuromuscular responsiveness is not the same. Time of day is not a neutral variable. The replacement behavior. Where logistically possible, shift at least 2 to 3 sessions of sexual activity per week to morning hours, specifically within the 6 to 10 a.m. window. This single adjustment, applied consistently, produces measurable improvements in arousal quality and ejaculatory completeness within 2 to 3 weeks for most men over 60. Craig, 67, a retired engineer, was experiencing what he called declining reliability over 2 years. His testosterone panel was low normal. No pharmaceutical intervention was recommended. After shifting his solo activity to mornings for 1 month, he described the change as returning to a version of myself I thought was gone. His morning erection quality also improved as a secondary effect. I had no idea the clock mattered that much, he told me. Myth number 5 is the one most men have never heard discussed in any context, which is exactly why it has been causing quiet damage for years. Myth number 5 is that what happens after ejaculation has no physiological importance. The myth in full. Most men treat ejaculation as an endpoint. What follows, rest, sleep, or resuming activity, is a matter of comfort, not biology. The act is complete. Recovery happens passively. Nothing intentional is required. Why this myth persists. The post-ejaculatory period is not visible or symptomatic in an obvious way for most men. Unlike the preparation and execution phases, which have clear feedback loops, the recovery phase produces no obvious signal when it is handled poorly. The damage, slower return of erectile readiness, reduced morning erection quality, next-day fatigue, accumulates gradually and is attributed to aging rather than to the absence of recovery practice. The research correction. After ejaculation, the male body undergoes a specific hormonal sequence. Prolactin rises sharply, the hormone responsible for the refractory period, and dopaminergic tone drops temporarily. Pelvic floor muscles, which contracted forcefully during ejaculation, require a structured relaxation period to return to resting tone. Blood is redistributed from the pelvic region. In younger men, this sequence resolves quickly without assistance. In men over 60, the resolution is significantly slower. Research from the University of Queensland, tracking 1,150 men over 60 for 12 months, found that men who implemented a structured 5-minute post-ejaculatory recovery protocol reported a 41% faster return to sexual readiness and significantly better morning erection quality compared to men who reported no recovery practice. That 41% difference represents, for many men, the difference between a reliable morning erection and its absence. Think of it like the cool down after a cardiovascular workout. Stopping immediately after peak exertion is not neutral. It interrupts the physiological processes that make the next session possible. The cool down is not optional. It is part of the session. The replacement behavior. Implement a non-negotiable 5-minute post-ejaculatory protocol. Step 1. Light movement. Walk slowly around the room for 2 to 3 minutes. Step 2. Drink 250 milliliters of water immediately. Step 3. 5 slow diaphragmatic breaths with intentional pelvic floor release on each exhale. That is the complete protocol. It requires no equipment, no special preparation, and less time than most men spend checking their phones after the fact. Thomas, 70, a retired surgeon, had been managing what he described as increasingly unreliable mornings for 3 years. His hormonal and vascular assessments were unremarkable. After implementing the post-ejaculatory protocol consistently for 4 weeks, his morning erection quality had improved to a level he described as a decade younger. The recovery phase, he told me, was the missing piece the whole time. Nobody ever told me that was even a category. Myth number 6 is the most important myth on this list, and the one that, once corrected, changes how you interpret every other aspect of your sexual health. Myth number 6 is that sexual health after 60 is a separate category from general health. The myth in full. Most men, and frankly, most physicians, treat sexual health as a standalone domain. Erectile function, ejaculatory health, libido, and prostate status are managed as isolated concerns, separate from cardiovascular health, metabolic function, sleep quality, and inflammatory status. When sexual function declines, the search for cause and solution stays within that isolated domain. Why this myth persists? Medical specialization reinforces it. A cardiologist does not typically ask about ejaculatory health. A urologist does not always review sleep duration. Endocrinology, urology, and primary care operate as separate silos, and patients move between them without anyone synthesizing the complete picture. The research correction. Sexual function in men over 60 is not a separate system. It is a downstream readout of systemic health. Endothelial dysfunction, the same process that underlies cardiovascular disease, is the primary vascular driver of erectile difficulty, manifesting on average 7 years before a cardiac event. Chronic sleep deprivation of fewer than 6 hours per night reduces testosterone by up to 15% within 1 week, as established in a University of Chicago study of 531 healthy men. Fasting glucose above 100 milligrams per deciliter impairs nitric oxide pathway function, directly reducing erectile and ejaculatory quality. Systemic inflammation, measurable through elevated CRP and interleukin-6, directly suppresses the hypothalamic pituitary gonadal axis that governs testosterone production. A Massachusetts General Hospital study of 2,400 men over 55, tracked over 5 years, found that men who optimized all 4 metabolic markers, blood pressure, fasting glucose, sleep duration, and inflammatory markers, had a 52% lower rate of significant sexual dysfunction compared to men with 2 or more markers outside optimal range. Sexual function is not a domain. It is a report card. Think of it like judging the performance of a car by only looking at one system, say the tires, while ignoring the fuel quality, the engine temperature, and the oil pressure. The tires matter, but they operate within a whole system. You cannot optimize one component in isolation and expect the car to perform. The replacement behavior. At your next medical appointment, bring sexual health into the conversation about your metabolic panel. Ask specifically about fasting glucose, CRP, sleep duration, and free testosterone, as a connected set of markers, not as isolated data points. Request a baseline and a 3-month target for each. Treat your sexual health outcomes as the integrated feedback they actually are. Donald, 72, a retired physician himself, came to me after 3 years of progressive sexual dysfunction he had been managing in isolation, trying topical treatments, adjusting timing, experimenting with supplements. His metabolic panel told the story his isolated approach had been missing: fasting glucose of 109, CRP of 3.8, averaging 5 hours of sleep, and free testosterone at the low end of his age range. 12 weeks of integrated metabolic intervention produced improvements he described as reversing 3 years in 1 quarter. I spent 30 years in medicine, he told me, treating systems in isolation. I was doing the same thing to myself. Here is your complete protocol, beginning tonight. Tonight, Drink 500 milliliters of water before bed and note your average sleep duration. If it is below 7 hours, that is your first priority before anything else. Also tonight, perform 5 minutes of diaphragmatic breathing with intentional pelvic floor release. Inhale slowly, exhale fully, allow the pelvic floor to drop on every exhale. This is your hypertonicity baseline reset. Starting tomorrow morning, shift your sexual activity window to 6 to 10 a.m. where possible. Note your morning erection quality on a simple scale of 1 to 10. This is your primary physiological readiness indicator going forward. This week, implement the 5-minute post-ejaculatory recovery protocol after every single session without exception. Movement, water, 5 breaths with pelvic release. Begin grip pressure reduction if technique recalibration is relevant for you. Introduce a water-based lubricant. This month, review your last metabolic panel: fasting glucose, blood pressure, CRP if available, and sleep average. If any of these is outside optimal range, book an appointment with your physician and bring this video's framework into the conversation. Request free testosterone measurement if not recently obtained. Ongoing. Maintain minimum 8 to 12 ejaculations per month for prostate health. Track morning erection quality weekly. If it trends consistently upward over 4 weeks, your protocol is working. If it remains flat or declines, clinical evaluation is warranted, and I encourage you to pursue it without delay. Arthur, 64, a former accountant, applied the complete framework across all 6 myth corrections simultaneously.